we're going to talk about threats to skin and tissue. And this is Unit 3B. And it covers Chapter 15 of your book. So it's just kind of an overview of what cancer is. So what is it? It's defective cellular proliferation. And you say, Mrs. Lewis, what is proliferation? Well, proliferation occurs when your cells live and die, right? So let's say we've talked about when you get sick, what happens? Your white blood cells go up. So old cells die, new cells are made. So proliferation is basically those new white blood cells coming on the scene. Okay? Another example is the liver. You know how the liver can regenerate. There's cells specific to the liver, and when there's damage there, those liver cells proliferate. Okay? So that's kind of what proliferation means. But this says defective cellular proliferation. So something is wrong. So let's talk about the cells. We're not going to spend a lot of time here, but in order to really understand this, you got to understand a little bit what's going on with the cell at the cellular level. So I told you what, and now we're going to talk about the how. It starts at the cellular level. So it starts as an undifferentiated cell. All our cells. All our cells come from stem cells, right? They all start out as stem cells, and most all of our cells have the same DNA, right, in the beginning. But then they go to different parts of the body, right? So you have your liver cells, you have your skin cells, your integumentary, you have cells, all different cells, and they become differentiated. That just means they become like wherever they are. So another way to explain that in really, really simple terms is you have two children. They both came from the same parents, but one child all of a sudden starts doing sports and the other child does art. Well, they get really involved in sports. That's all they think about. They want to go to sports camps. They do sports. Well, they are differentiated into sports. Whereas the other child likes art, so they are differentiated into art. So that's kind of how cells do. They kind of, wherever they are, they pick up that area of the body, and that's how they operate. So your liver cells operate in the liver. So your normal cell starts undifferentiated, but it becomes mature and it differentiates. So it becomes like the tissue that it is where it is. It starts as a stem cell. Yep. So it differentiates depending on where it is in the body. Example, liver cell, liver, or liver, the liver cells, skin cell. And then all cells live and die, right? It's a constant process. All cells live and die, and then proliferation occurs if the body has a need for more, like when you are sick. Okay? So this is normal. So I always like for you to understand normal so that you can understand abnormal, right? And the cancer cells are abnormal.
What makes the cancer cells abnormal?
We're going to talk about that.
Oh, okay.
We are. We're about to talk about that. So, with cancer cells, it starts with a normal cell. They can be undifferentiated or differentiated. But the cancer cells invade the cell wall boundaries and multiply and spread. So, Think about somebody that you know that likes to push the boundaries. Maybe your kid. They like to push boundaries, or somebody that you know that just, you try to set these boundaries, but they keep pushing. That is like a cancer cell. Yes, it has boundaries. Our cells have boundaries, but the cancer cell will find a way in, find a way around that boundary, and it'll push its way into the cell. And it invades the boundaries. And they proliferate continuously. You may hear a term when you're reading called contact inhibition. And that is basically the ability to metastasize or spread. Basically, that's what the cancer cells do. And they can also cause cell death. So they have contact inhibition. Basically, like we were saying, they can break those boundaries, right? Talking about the cellular level, you've heard of malignant, which is a cancer, right? And then you've heard of benign, right? Now your benign neoplasm, which is just a tissue of cells, right? A bunch of clump of cells that are growing, undifferentiated. They are, in general, benign neoplasms are well differentiated, right? They're just this growth. They don't spread. They don't invade. They can invade, but they're not cancer, right? If you've ever known anyone that had a lump and they were like, "Oh, the doctor said it was benign," that is a good thing, right? That means that it is not cancer. But a neoplasm is just a mass of tissue that results in growth. It can be malignant or cancerous. It's just basically the cells divide more than they should. Or they die when they don't die when they should. So it's just a big mass of tissue sometimes, and instead of dying off, it just grows. So that's a neoplasm. And a neoplasm can be benign or malignant. So you've got many diseases, but one definition. So your cancer is a group of diseases that does not follow the normal cell process, right? We talked about the cell process, normal and so it doesn't follow the normal cell process. And the exact patho is unclear. There are all these theories, and your book talks about how they think that it happens. But there's some other things out there that are just questionable. I'm sure you've heard stories where we don't, it's just unexplainable. Well, that's why they have to put in here the exact patho is unclear, because there are some weird cases out there. They do feel that your immune system is a huge factor. And back to test 1, aren't we? So your immune system is a huge factor, or is a factor. And we're going to talk more about that. And so your characteristics of your malignant cells, they have altered cell membranes, like we already talked. They have tumor-specific antigens. And they invade and metastasize. So they invade and spread. Invade and spread. So there's different ideas of how or why this happens. So I think I wrote why on this one. Why? So there's different theories, and a lot of them are proven, that viruses and bacteria can cause cancer. Who can think of some viruses that have been linked to cancer? HPV, very good. Epstein-Barr. HIV. Hepatitis. So there's viruses that have been linked to it. Bacteria as well. Physical agents. What are some physical agents that have been linked to cancer?
Smoking.
Pesticides.
Yeah, those are, chemical, physical, yeah. Radiation. Y'all seen that documentary on Chernobyl? They all, ended up, a lot of them, if they did get exposed, ended up with leukemia and died anyway. Some of them died immediately. So radiation is a big exposure. So that's why we don't just go and do a mammogram on every 20-year-old, right? Because you're exposing them to radiation. My sister, they found a lump in my sister's breast when she was like in her 20s, and they weren't gonna do a mammogram. And I'm like, why aren't they gonna do a mammogram? And they were like, we don't want to expose her to the extra radiation. We can just look with an ultrasound, which is much less. And a lot of times they'll do a needle biopsy to look to give a better idea if there's a lump there. But you don't want to expose anybody to unneeded radiation. Even like if you work somewhere in healthcare that where there's radiation, you usually have to wear a little sensor that lets you know and lets your employer know if you're getting exposed to too much radiation. So radiation is definitely an agent that can cause cancer. Chemical agents, y'all talked, definitely smoking, anything, you think of anything you can inhale. I know different plants, like where I used to live, there were paper mills, and a lot of the men would end up with cancers because they were constantly inhaling some of the carcinogens. I don't know if your book talks about it, I read it somewhere about a year, this was early 1900s, I think. A scientist, Percival Potts, realized that the chimney sweeps, the guys that did the chimney sweeps, was getting scrotal cancer, which I would think lung cancer, but and they have linked like when you eat a lot of grilled meats and things, that increases your risk. Grilled, smoked, charcoal, the things. I know. It's not necessarily just the grill, it's the charcoal. Oh yeah, there's a whole documentary on Netflix about how eating bacon, one slice of bacon a day, can cause cancer. Nitrates. It's the nitrates in the bacon. Or any of the meats.
There's this lady on the news.
All right, so chemical agents, and then back to genetics and familiar factors, right? So sometimes you get bad genes. Sometimes it's in your genetics that you're more prone to getting cancers. And there's a whole bunch of stuff in your book if you want to read all that, definitely. But I would just know that genetics is a factor. You don't have to know all those specifics. It's good to know, especially if you think you might work in HEMOC or oncology. Dietary factors, we already talked about the nitrates. They've even linked eating high fat from meat to cancers. Again, depends. Some people can eat as much as they want and not have any problem. But it most likely is due to what we're feeding the animals, right? Because we feed them some junk.
Those hormones.
Yep. Yeah, my husband used to tell me some things because he used to work heavy machinery, and they would do work for farmers. And he would tell me some of the things they would feed the animals, and it was gross. Yes.
I just read big and you have the vanilla wafers and everything on this.
So I really have a strong opinion that it is what we're feeding our livestock that we are seeing so many problems with our health. And then, of course, hormonal agents. You got to think about estrogen and progesterone. You know, a lot of times when women are menopausal, they'll give you the hormones, and they just they can increase your risk of cancer. Not everybody has that problem, but some people do. Again, it's your genetics. I wrote page 259 down here. I think there might be a chart or something.
Yeah.
Oh, no, it just talks about hormone therapy, that's all. So this is kind of the why. Why does it happen? So there's a bunch of different reasons. And like I said, sometimes people don't even know why. But our immune system, I told you we were going to talk more about that. Our immune system definitely plays a factor, plays a big role. Remember when we were talking about the immune system, how our body has self and non-self cells? So the immune system has the ability to distinguish between self and non-self cells. So think about your patient that gets a transplant. They get a transplant, and that's a perfect example of a non-self cell, right? They're getting a transplant, even though they do all the matches. So in order for your body not to reject that transplant, a lot of times you'll have to go on immunosuppressants. So they suppress the immune system so you don't reject the transplant. So that is a perfect example of self and non-self. But our immune system can detect and destroy cancer in its early stages. Your lymphocytes continually check all your surface antigens and detect and destroy abnormal cells, right? Remember, back to test 1 again. All these white blood cells that do all this work for us, those macrophages that eat up those cells, right? So our immune system is huge in helping us not get cancer. But think about someone who's immunocompromised, someone that has autoimmune, someone with immune system failure. They are more susceptible because you got that cell wanting to break through those boundaries, and your immune system's not fighting as good. So they're more susceptible to cancer, right? As far as the epidemiology, it's a big word, isn't it? Epidemiology. All ages can get cancer. I told you about my 14-year-old nephew. There is a higher rate of people getting cancer greater than 55. Hence, all our preventative medicine. You know, when you're 40, you're supposed to have... No, when you're 50, you're supposed to have a colonoscopy. When you're 40, you're supposed to have a mammogram. 40, 45, I forget exact. So there's a lot of preventative medicine out there trying to prevent this, but all ages. Their prostate is most frequent. So males get, there's a high incidence of prostate cancer, lung cancer, and colorectal, and then women, breast, lung, and colorectal. So there's There are a couple of charts in your book that talk about this on page 235.
What page?
235. There's cancer incident by site and gender, and then cancer deaths by site and gender. I wouldn't try to memorize this chart, but just be aware that there are male have higher risk for prostate, women breast. I thought it was interesting. Men can have breast cancer too. Miss Michaels is going to talk to you about that next week.
Speak to that.
But
Can I just say one thing? Sorry to interrupt.
Oh yes.
Since you brought it up, I've got models out. I requested them actually a week early. So if you're on break, if you want to practice doing a self-breast exam, I've got the models out. So
Yeah.
to utilize them.
Practice on each other.
What was that?
She said practice on each other.
Whatever you feel comfortable with.
In here that probably can't do that.
No. Well, here's what we're not gonna do. Leave it up to Brooke. Okay, so. I thought it was interesting, though, that more men than women die of cancer. I thought that was an interesting statistics. Because you hear so much about breast cancer. But I feel like, not to be stereotypical, but a lot of times men, they are working and they're not saying that they don't go and do their checkups as much as women, because they're just not into that. A lot of men don't like doctors. They don't like doing all that. Right. And they don't like no prostate exam. What? So I just wrote who here. So who gets cancer? Everyone. Anybody can get cancer. I mean, you go down there to all children's and you see all the little babies, even babies, right? All ages. So what are some risk factors? We kind of already talked about a lot of the risk factors, but age is definitely one. Like I said, greater than 55 has a higher incidence. Genetics, tobacco use, because even not just the inhalation, because inhalation of tobacco, THC, and everything increases your risk, right? Because it's a carcinogen. But think about when they put it in the mouth. So those people, they get mouth cancer a lot of times, right? So tobacco in general, there's a high risk. Alcohol, of course, again, a lot of alcohol is not good for your body. It's a carcinogen. Chemical agents, immune disturbance, we already talked about that. If someone has a low immune system or some autoimmune stuff going on, their immune system's not working as well, they're more prone, they're more at risk. Geographic location. Have y'all know, this is funny, but like what I was telling you, back in the town where I used to live, a lot of the men that worked at the paper mill would get cancer. So it was a higher incidence in that geographic location of cancer, just because of that. I mean, it was because of that paper mill, but also because of a lot of farms, right? What do they do with farms? Pesticides. What about the people working with those pesticides? They're inhaling them. Whether they realize it or not, they can take all the precautions. They're touching them with gloves usually, but still inhaling them. So that area that I used to live, that geographic location, had a higher incidence just for those reasons. So there are different geographic locations that have higher risk factors. And then there's miscellaneous. If y'all ever heard of some just crazy ideas, like people think, that, and they've done studies too where they're saying, somebody got cancer from cell phones. Y'all ever heard that? Deodorants, the parabens and things. They're doing that would fall kind of under miscellaneous, of course. Could be chemical agents too, or baby powder, artificial sweeteners. Have y'all heard that? The water bottles, the BPA in the water bottles. They say that's increasing the chances of breast cancer. And then, of course, fluoride. There's also an increased incident of fluoride. People getting cancer from fluoride. So there's all kinds of things out there. Of course, we've already talked about gender, race, diet. Your book does say that, a high-fat diet is more prone to getting cancers.
I might be on the test you mentioned twice.
It could. As far as classifications is carcinoma is a classification, lymphoma. I think I wrote stuff on this one, so I'll page 204, table 15.4. So carcinoma is epithelial tissue tumor, right? Lymphoma, lymphoid tissue, lymphomas, right? Leukemia, bone marrow or plasma cells. That's where the cancer. And then sarcomas are connective tissue. Page 204, I believe. Oh, no, that's not right. 254?
15.4 is on 239.
Okay, 239.
Oh, wait, that's figure. not
Nope.
table.
240.
Yeah,
240.
is table.
Oh, I have dyslexia. I wrote it on page 240. I listed out. So they usually start with what classification of cancer is it, right? When they're when they're listing it, say carcinoma, and then they'll have some numbers after it. And we're going to talk about all these numbers right here. This right here, this classification just helps with diagnosis, treatment. It's kind of a communication, a standard of communication across the board for medical professionals, so that if they go from one doctor to another, say they get a second opinion, then they have this classification for the doctors to know exactly about the cancer. Because any oncologist is definitely aware, or an oncology nurse is definitely aware of this. So, 0 is cancer in situ. In situ. This is one of your terms. And it's just a neoplasm whose cells are localized and show no tendency to spread. So it's basically kind of a contained. Did you want to say something? Superficial.
So it's like on the first layer.
So when we're talking about, you're talking about like skin cancer, right? So when we're talking about colorectal cancer, or cancer in your intestine, so a cancer in situ there would be just right on the surface of the mucosa. It wouldn't be in the submucosa. So does that make sense? So it's right on the surface, and it's not. It hasn't invaded the other space, the other tissue. Okay, so that's cancer in situ, or I say situ, situ. So the grading is basically, you've heard people say, it's stage 4, it's stage 3. The grading is basically how aggressive are the cells, how aggressive the cells look under a microscope by the pathologist, whoever's reading it, whoever's looking at those cells. they determine, so think of it like your teacher grading your paper. They determine how it is, right? So they grade it by looking at how aggressive the cells look under a microscope. So your pathologists that make all that money, yeah, they've got to have a lot of education, a lot of chemistry, physics, a lot of chemistry. Huh? This chart for this. So how are we gonna find all this? Did y'all need me to go back? Everybody got that? Diagnostics. A biopsy is your gold standard, right? So once they biopsy it, they can look at it closer. Like I said, the pathologist will look at it under the microscope, and they can give the histologic and cytologic exam. They can do needle biopsy too, like we talked about. A lot of times they'll do that with breast cancers, or different tumor cancers. Y'all do a lot of scrapes at where you work, Renee, right? So a lot of the skin cancers, they'll do a scrape and they'll biopsy it that way. Sometimes they'll even do a core or excisional biopsy where they'll take a piece out. Often if they think you have cervical cancer, like if you get those high grade results when you get your pap smear done, and they do freezing or whatever, and you still have a high grade, or you still have precancerous cells, sometimes they'll do a core biopsy and they'll take out a bigger part, a piece of tissue. So there's different types of biopsies, and it can be obtained several ways. But it helps us yield the tumor identification that we just talked about. So an example would be a carcinoma, grade 1, stage TIS, NOMO. What does that mean? No nodes, no mets. What's TIS? Tumor in situ. Good. So it was contained. As far as lab tests go, there are many. There are many blood tests that they sometimes will do, but those are more, a lot of times they're more for tumor markers. I have known doctors to do them to take a closer look, like a CA-125 if they think there could be ovarian cancer. But a lot of times they can get false positive, false negatives with those, so they're not as diagnostic as a biopsy. Other conditions can cause these to be elevated. I know that I knew a person who had a cyst on her ovary, and they did an ultrasound, and it looked like it was solid. It wasn't liquid filled. So they decided to just go ahead and do a CA-125, the doctor did. And it was positive, but then they found out that she had endometriosis, and it was a false positive. She did not have cancer. So So you can't necessarily use that to diagnose. It's really just a way for the doctor to kind of have an idea of what's going on.
They usually help you get to like the next step. The same 125.
Right.
to do
Once
the biopsy.
once it's confirmed that you have cancer, it helps them know how involved it is it responding to the chemo, that kind of thing.
Okay.
There's all different ones, CEA, CA 125, CA 15, there's all a bunch of different ones. But a biopsy gives you the most definite diagnosis. Well, yeah, that's like a diagnostic. PET scan's really good as far as deciding if there's more cancer. What do you think my nephew did? How do you think they found out he had leukemia? CBC, right? He wasn't feeling good. And his mom ignored it a little bit because he's a teenager. And she thought he was being lazy. But he got to feeling really bad. So a lot of times with especially the leukemias and the blood cancers, they'll do a CBC. And you'll see their white counts will be down, or their platelet, or their plasma cell, it'll be off. So blood, in the body, they're going to try to surgically remove it. And we'll talk about that a little bit more when we talk about colon cancer, because they do take those out, the colon. If it's a breast cancer, they'll remove the whole breast sometimes, or they'll remove just the tumor. Depends on the grading and all. So surgery is definitely a treatment, and then a lot of times radiation and chemo, right? So let's talk about radiation. So your 4 goals of radiation is you want to shrink the tumors, right? That's the goal. You want to shrink them. You want to slow those cells down, right? You want to slow that invasion, that proliferation of those abnormal cells. The ultimate goal is to kill those cancer cells, right? But you can't blast them with huge radiation because it kills the person. So that's the goal, though. And then destroy as few healthy cells as possible. It's kind of a tit for tat. And then another goal is you want to minimize the radiation effects, right?
So the kill and the destroy as little few healthy cells, they're together. That's one goal together.
Yes. Radiation can cause injury, right? If you've seen any of those, like I was saying, those different movies where there was radiation released into the environment, you see how people suffer. But they are trying to use it for some good and killing off cancer cells. There are different types of radiation. There's internal. It's called brachytherapy, or external teletherapy. And we're going to talk more about both of those. Internal has various delivery systems. It can be an implantation, it can be interstitial, it can be intracavity. For prostate, it can be permanent implants. The side effects, though, you have to teach and be aware and make sure the patient's aware that they are radioactive, right? They have radiation in them. So you have to be aware of that. The side effects are just like with any radiation. Decreases the immune system, decreases your counts, your white counts, your blood counts. Because it's killing the good cells as well as the bad cells, right? It's trying to. As far as education, we need to make sure we have them limit time spent in direct contact with other people. So you want to minimize exposure dangers. Most patients are going to need a private room. Proper handling of bodily fluids. They have to be disposed of in a radioactive container. Monitoring of exposure. So you may be having to wear a radiation exposure tab to make sure you're not if you're taking care of these people on a regular basis. And you have to educate the client to make sure they're aware of these things. If, say, you're taking care of a patient with implants and it comes out, you're not just going to go pick that up with your bare hands, are you? No, you're going to have special long tongs or whatever so that you don't have to touch it. And it has to be disposed of in a radiation bin. So, making sure you understand all that. And of course, if you work, I worked at a smaller hospital that didn't have a HEMOC floor. And occasionally we get patients that had implants. And, they would make sure we knew how to take care of them and to be careful and to minimize exposure to them. That's when you definitely do your cluster care. You try to get everything done in that room while you're going in there one time so you don't have to keep going back in there and exposing yourself. External radiation, this is common. That's, they'll mark the location. If you ever taken care of anybody that had drawings on them because they were getting radiation, they usually will mark the location. I think your book talks about it on page 255. I don't know if there's a chart or not.
The external?
Yeah, the external.
250.
Oh, it starts at 250?
Small paragraph.
So it goes from 250 all the way to 255. Or no, two.
From 250.
But it goes on and talks about the different problems. It includes chemo and radiation therapy together as far as your nursing management. So it continues on. It shows you some pictures of some burns on a patient on page 255 from radiation, and how the radiation, that's what I was wanting you to look at, is this chart on page 255, table 1512, the different skin reactions that can occur. I would look over this chart. I'd make sure I read it. Page 255. make sure you look over that chart, because they can get these burns, and the skin is just like any burn, right? But you want to tell your patient not to go and exfoliate with exfoliation buffers and things like that. They just need to clean the skin gently. Okay? They can use some aloe vera cream or gel, but they don't need to ice it, because what could happen if you ice it? Well, if you have, right, it constricts. So if it's already damaged, then cold is going to constrict it and probably cause further damage. So you don't want to scrub it. You don't want to exfoliate. If you do exfoliate, be gentle about it. I heard this story once that a person was putting coconut oil on them, and then they were going to radiation. What do you think was happening? They were frying, weren't they? So they need a little more teaching, didn't they? They just, avoid tight-fitting clothes, just comfort measures, right? Definitely. What?
The room probably smelled good.
Or either it smelled like burning flesh. So, yeah, you're definitely a lot of education here. I'm sure this person had education, and she just wanted to smooth out those scales with that coconut oil. And it was not a good thing. They definitely, it should be a given, right, that you avoid the sun. But again, everybody don't think about things. They're used to going out in the sun, but they need to avoid the sun. Maybe wear a shirt if they're going outside, and sunscreen. A lot of people don't realize that the sun can penetrate your clothes. You still need sunscreen if you're going to be out there a long time, if you're going to be, if you're sensitive to the sun. So there's no that that there's side effects. Unless you've been living under a rock, you know that people get really sick on chemo, right? We're going to talk about some of those. So we're going to keep on going. So, extravasation is a complication of chemo. Hence why they use a central venous access device now. These people, chemo is very, very hard on the veins. It is a vesicant, which means it kills tissue. It can cause extravasation. So your vein patency must be assured. You have to monitor for anaphylactic reaction. And we have to use caution when we're preparing this stuff as well. Okay? If you do become a chemo nurse or an oncology nurse, then there's a whole process of getting certified to administer it. So that's more schooling for you. So that you won't make these mistakes. And you won't injure yourself as well. So we want to definitely avoid that. As far as some of the side effects, we want to make sure, because we know our patient's going to be immunosuppressed. So anything that goes along with immunosuppression is a clinical intervention, nursing implication for these patients. So we need to teach them, avoid crowds, meticulous hygiene, frequent hand washing. They need a low bacteria diet. They need to know what signs and symptoms to report. What does that mean? Who can tell me what that means? We're going to be monitoring labs, assessing, because We're taking the vitals more frequently, temperature more frequently. And then, of course, your neutropenic precautions. What does neutropenic mean? Right, so your neutrophils are your white blood cells. And what are your normal white blood cell count?
140,000 to 400,000.
Those are platelets.
4.5 to 10.
4 to 10. Yep, 4.5 to 10.
Anybody who goes inside needs to wear a mask.
Yes, it's recommended. Yeah, if they are definitely immunosuppressed. A lot of times they need to eliminate uncooked foods too, because raw foods have more chance of bacteria. Oysters. This is my nephew in the green, and that's his friend. Both of them from the same town had leukemia at the same time. Isn't that crazy? But that's him with his head all shaved. He doesn't have hair, and they both, I think this other guy's got a stuffed animal. They both have masks on. Because why? Because they're immunosuppressed, right? They're in a common area at the hospital. There's not any more kids there, but still, they are out of their room. So they have to have masks on. So they need to avoid crowds. We already talked about this. No signs and symptoms to report. As far as thrombocytopenia, what is it? We talked about neutropenia or low white count. Low platelets. So what are we going to see with this? We need to monitor stools, monitor urine. What is a platelet count, Sarah?
No, I forgot. 140.
Yep. Whatever your book says, 150 to 400, 500. When would you worry? If it's low, right?
Bleed out all over the place.
So, because what do the platelets do? They're the plug, right? When you clot. So, if it's low, then you could bleed. So, less than 150,000. A lot of times it even gets less than that, like 20,000. You're going to see bruising and oozing, okay? So they need to use an electric razor. What is avoid trauma? Like, nobody wants to be have trauma. How could you?
Like heating stuff.
Right, like falls, avoid like with kids and teens, they need to avoid contact sports. Just anything that could cause them to have some trauma.
Avoid getting into fights.
Yeah, avoid getting into fights. Avoid invasive procedures. No aspirin. No flossing. Why do you think they don't need to floss? They bleed easy, right? So they need soft toothbrushes. So that's a lot of your nursing management. And as far as this is stuff that we have to teach them, right? Because it's not common knowledge. A majority of patients, they might get on Google and read about it, but then they don't really understand. They still need you to teach them. Some of the side effects of chemo is the stomatitis and mucositis. So the same thing, soft toothbrush, avoid alcohol-based products because alcohol dries things out. It can lead to sores. Paradex is just a type of swish that's not alcohol-based that sometimes they'll use. I think it's got some peroxide in it, but it's to prevent infection in the mouth. We need to assess them daily for lesions. They need to learn to assess themselves for mouth lesions. They can have some moisturizing agents as well for the mouth. They definitely need to avoid smoking and alcohol because it can potentiate this and make it worse. And avoid hot, irritating foods, so spicy foods and citrus foods sometimes can irritate these. So we need to teach them that. We don't just say, avoid spicy foods. No, we got to teach them about the food. So think about anything that would cause your mouth to burn. You need to talk to your patient about it. Citrus foods, spicy foods, things like that. And then teach them signs and symptoms to report. Sometimes, too, if we can help give them like an oral like an oral gel to help with the pain, it can also help with nutrition. Because if they're hurting when they eat, they're not going to eat, right? Or they're not going to want to eat. So they do make medicines to help kind of like oral gel to kind of make it not as hurt, what's it called, like a lidocaine?
Benadryl.
Yeah, things like that will help.
Triple mouthwash.
Yeah, the magic mouthwash. Yes. And that causes chemo. Chemo causes hair loss, right? It depends on the type of chemo. I've seen people get chemo and not lose their hair, so it depends on the type of chemo. We, as far as nursing, we should help teach them to choose a wig before they lose their hair, right? Damage occurs at the hair follicle, so washing the hair or washing the hair less really doesn't affect it. We need to make sure that telling the patient that it's going to grow back is not helpful, right? No. Not in the moment. No. They don't really need to hear that. That's like just kind of non-therapeutic communication. Oh, it'll grow back. That's something, sometimes we think before we speak before we think. Yeah, a lot of times it grows back a different texture, sometimes a different color. I have seen people have straight hair and it comes back curly, or people that had curly hair, it comes back straight. Yeah, it's pretty interesting. But we are to allow them to have expression of feelings. They need to express their feelings. If they're feeling like they don't, they're upset, sometimes that might be the time to sit with them and let them cry. Or, let them vent. Whatever it takes, this might be the time that we just sit with the patient. So let them express their feelings. Gerontologic considerations is just, as people get older, they have a higher mortality rate. Signs and symptoms can be missed. They'll need a more functional assessment, more focused. Does quality outweigh quantity, that kind of thing. So a lot of times, I have known some people that were older say they don't want to do chemo. They'd rather just have quality of life, what's left of it. So, you also have to be considerable of what they want. Educate them. But also, if they're 80 years old and they don't want to be sick from chemo, then, we got to be accepting sometimes as well. These are just the warning signs of cancer: caution, change in bowel or bladder habits, a sore that does not heal, unusual bleeding or discharge, a thickening or lump in the tissue, indigestion, frequent indigestion or difficulty swallowing, obvious change in a wart or a mole, nagging cough or hoarseness. I actually had a